Hello, my name is Gord Asmundson. I very much appreciate the opportunity to speak with you today about non-pharmacological approaches to treating chronic pain. I wish I could be there in person. In the next few minutes, I'm going to introduce you to a family of interventions commonly referred to as cognitive behavior therapy, or CBT. I will also review how CBT is generally applied in the context of chronic pain, summarize the evidence for this approach, and end with important and future considerations. As I mentioned, CBT refers to a family of interventions, so it is not a single intervention, but instead a collective of tools that share in common a focus on the contributions of maladaptive patterns of thinking, maladaptive behaviors, or both maladaptive thinking and behaviors to distress, suffering, and functional limitations. These interventions are time-sensitive, typically delivered in 1-hour weekly sessions, plus weekly homework over the course of 12 to 16 weeks. They are structured, rooted in the present, and are characterized by therapist-directed learning to more effectively cope with clinically significant symptoms. A core assumption of the cognitive behavioral approach is that dysfunctional thinking, rather than external situations or events, are central to the experience of distress and suffering. Consequently, many CBT interventions have a primary focus on dysfunctional thinking. CBT for chronic pain had its origins in the 1970s with the early behavioral work of Fordyce in pain populations and the cognitive work of Beck with depressed individuals, so it's been around for approximately 4 decades. As applied to people with chronic pain, CBT focuses on changing negative thinking associated with pain, thereby decreasing suffering and distress and increasing adaptive coping and functional ability. To illustrate, consider this example of a cognitive behavioral conceptualization of post-injury pain wherein the outcomes differ depending on the way one thinks about their pain experience. The person who doesn't have catastrophic beliefs about their pain will gradually resume activity and recover. On the other hand, the person who believes such things as my pain will never go away and I can't do anything because it hurts so bad is likely to be very guarded in the things they do, will avoid most or all forms of activity, and will become mired in a vicious, self-perpetuating cycle. CBT would assist this person in reframing these negative thoughts through a series of structured cognitive exercises and behavioral experiments. A cognitive exercise might focus on challenging the accuracy of the thought and finding a more accurate alternative, such as, I'm in pain, but there are a number of things I can still do. While behavioral experiments would be designed to test the veracity of the negative and alternative belief and provide evidence for one over the other. In most cases, the person's negative beliefs are not supported by the evidence. This process, which can be delivered by trained therapists in individual or group therapy formats or via online therapy or e-health platforms, aims to break the vicious cycle that perpetuates pain and thereby reduces distress, suffering, and improves functional ability. The process does not necessarily address the pain experience directly, but rather thoughts and behaviors associated with pain. As such, pain severity may remain unchanged. Interestingly, however, a number of controlled trials have reported improvements in various outcomes, including pain severity. So what is the evidence for the efficacy of CBT for chronic pain? Based on the available literature, it appears that CBT is the primary or gold standard psychological treatment for various presentations of chronic pain. There have been dozens upon dozens of meta-analyses of the many randomized controlled trials comparing CBT for chronic pain to various control conditions and other active treatments. In essence, meta-analyses summarize the magnitude of effects across studies, thereby providing an indication of aggregated effects. Meta-analyses show that CBT outperforms waitlist and usual care on various pain outcomes at post-treatment, with small to moderate effect sizes, but not at follow-up. Meta-analyses also show that CBT outperforms active controls on disability and catastrophic thinking, but not on pain severity or mood at post-treatment and follow-up with small effect sizes. Some trials have also shown that other psychological approaches, such as mindfulness-based stress reduction, are as effective as CBT. So, while CBT for chronic pain is far from perfect, and in the current Canadian health system can be associated with costly out-of-pocket expenses for the person requiring the service, it is better than many other options. It is also safe, not having the same risk profile as pharmaceutical or surgical interventions. It is accessible, with the potential for delivery in various formats. It's adaptable to primary care settings and collaborative step care approaches, and, as you will hear more about shortly, it can be delivered via online and e-health platforms. Importantly, despite all of its strengths, most people with chronic pain have never received CBT. Well, where do we go from here? What are some things to discuss and debate? More science is needed, specifically geared toward optimizing CBT interventions for chronic pain. What is the optimal treatment content? What is the optimal treatment delivery format? What is the optimal dose? Will the addition of booster sessions improve the long-term effects of treatment? What is the best method of delivery for addressing chronic pain that occurs in the context of co-occurring mental health conditions or other physical health conditions? These and other questions remain to be addressed empirically. Let me conclude with this thought. Based on the available evidence to date, I would suggest to you that innovative implementation strategies to improve access to CBT for all Canadians with chronic pain are needed, and that this family of interventions, cognitive behavior therapy, is a viable and much needed approach in a national strategy to address chronic pain. Let's employ CBT to help all Canadians learn how to function and even thrive despite pain. Thanks for your attention.